Dr. Ferris is particularly interested in educational and research strategies to grow palliative care clinicians and leaders and advance palliative care globally. And this lecture is part of that program. We have seen Dr. Ferris, he really travel a lot and he is really dedicated and committed to develop educational and research strategies and to develop palliative care education all over the world. His key accomplishment, if we consider there are many key accomplishments, to enumerate few principle, he is principal of palliative care interdisciplinary curriculum. He is principal of International Leadership Development Initiative and International Palliative Medicine Fellowship Program. He is member of board of International Association of Hospice and Palliative Care. He is fellow and past president of American Association for Cancer Education. And he is also author and editor of a model of guide hospice palliative care, which I think many of us read, based on the national principle and norms of practice. He has published and spoken widely on many palliative care subjects, including effective approaches to caring for patients and families, education, and program implementation. Today he has multiple education and honors, which you can see in his CV. We will send it to you, and he has multiple key publications, which will be definitely helpful in reading and upgrading your knowledge, especially the youngsters, those who are doing MD palliative medicine. Today, Dr. Ferris is going to speak an important topic, which I think we need to cover is extensively, that how to use opioids judiciously for cancer pain management and chronic pain management. Dr. Ferris, over to you. Thank you very much for accepting our invitation. All the people, those who have any question and queries, can write in the chat box. Arun will sort it out. Already people have sent questions, we have sorted out. But rest of the people, those who have any burning questions, please write down in the chat box. We will handle one by one at the end of the lecture. Over to you, Dr. Ferris.
Thank you so much, Dr. Sushma. What a delight to be with every one of you to share this event, and I'm excited for your Congress. This is wonderful. So let's begin a process of at least talking about this important topic: how do we effectively and carefully use opioids? First of all, I would like to say that I have no disclosures. I would also like to say I'm happy to share my PowerPoint presentation. You're welcome to use it and adapt it simply with attribution. So I think one of the important questions that we all need to ask ourselves is, do you or do I practice evidence-based medicine? I'm hoping that every one of you will say, yes, I do. So that becomes an important aspect of then my next question: do you prescribe all medications that we use in palliative medicine based on their pharmacokinetic data? That's the evidence. We have it. Are you using it appropriately? You know, efficacious, effective, and safe opioid prescribing is actually a model for the way we can prescribe most medications used in palliative medicine. So I really enjoy this presentation, and I see it as fundamental to what you and I do day to day caring for patients. So the first thing I'd like to start out with is the appropriate therapy for the pain is always based on us treating the cause, based on pathophysiology. I don't know about your training, but in my training, this was missing in a major way. It's important for us to remind ourselves that a painful stimulus interacts with nociceptors. Those pressure, chemical, temperature receptors are on our surface, right down to bone, stretches in our abdomen. They stimulate, the nociceptors stimulate transmission. We end up perceiving what's going on, and there's also modulation. So this is effectively what happens when the somatosensory system is functioning normally. And we need to understand where the different medications interact and what's the best treatment for a given situation. Now, of course, there's nociceptive pain, there's neuropathic pain, there's a mixed situation, and there's total pain. Opioids are appropriate many times, but they're also not necessarily the best therapy to start with. We should always be treating the experience of the patient with non-pharmacological interventions. Our nursing colleagues, counselors can intervene, particularly if there's a significant total pain component. We're going to think about pharmacological, and I never want us to forget the interventional procedures that might help our patient. A good example is a patient with pancreatic cancer where a celiac plexus block may actually mean that the patient doesn't need any opioids for weeks to a few months. So think of it as a package. You asked me to focus on analgesics, particularly opioids. I still think we need to think about this particular ladder. The question is whether you use step 2 or not, recognizing that the low dose morphine is actually equivalent to 50 milligrams of tramadol. That would be 5 milligrams of oral morphine. But what's appropriate becomes important, and we will need to know the pathophysiology to decide. So when an opioid is appropriate, we should prescribe it and titrate it using pharmacokinetics, at the same time assessing for the effects. What do I mean by the effects? Well, there's efficacy. Yes, we all use the severity score. Are we actually counting the number of breakthrough doses? If the patient's using a lot, that tells us probably the pain is not well controlled. If the patient is only using a few, we're probably very close in terms of efficacy. But it's not just about those numbers, is it? We know pain reduces people's movement, causes insomnia, reduces people's appetite, creates anorexia, messes with their concentration. Many people can't think at all because they're so focused on the pain, and people will have mood changes. At what point did you stop hearing me? I just noted that somebody muted me. How far did I get that you heard me?
Frank, we lost you for 1 second. It's okay.
Oh, it's okay. So you heard my comments about the efficacy slide, did you?
Yeah.
Okay, perfect. So let me continue. So in addition to the severity score and breakthrough usage, you and I every day need to ask our patients, is this helping you to improve your function, sleep, appetite, your ability to think and concentrate, hopefully making sure that you can still interact and do the things you like to be able to do. At the same time, it becomes important for us to monitor for side effects, that safety measure. You and I know that constipation and urinary retention are both primary effects of these opioids. And of course, the constipation is quite common. Fortuitously, urinary retention is not so common. Nausea, vomiting, many people get it, particularly the ladies in the group. You're more susceptible. The ones in blue are the ones that are particularly worrisome, aren't they? Fortunately, if we're using opioids appropriately, using the catch-up technique that I will demonstrate, hopefully we get some sedation before we get any of the other effects, and then we can either decide to reduce the dose, wait a little bit, or rotate to another opioid. Now, many people say to me, oh, but I'm worried about respiratory depression. Not very common. In fact, using a catch-up technique that I'm going to show you where the patient uses breakthroughs, testing with every dose. But if we do have obesity or sleep apnea, we just need to be aware of the situation and make sure we're monitoring the patient closely. So what are those dosing principles? Hopefully what I'm doing is reviewing for many of you, but they are foundational concepts. And as I teach, there are always people who are not following them. Why do I touch on this? Well, fortunately, our opioids, except methadone, all follow first order kinetics. We use these kinetics, in fact, with almost all of our medications that we use in palliative care. And fortunately, the clinical effect increases proportionate to the dose. Concurrently, so does the risk of side effects, both following first order kinetics. Hopefully you remember them from your first pharmacology classes, but I find many folks are prescribing the recipes and not using the evidence. So let's talk about it. First order kinetics apply when there's a predictable response to dosing and proportionate increase with each increase in concentration. You know the story. We give a dose, the plasma concentration increases as the medication is absorbed. As it's being eliminated, the plasma concentration drops. Pain decreases up until this maximum concentration, and then pain starts to return. The risk of side effects increases as we get to this maximum concentration, and then the risk of side effects starts to decrease. It's not as though the medication, I'm going to use morphine as my model, is absorbed at other sites in our body. It's water soluble and it moves with water throughout our body. Some of the other medications like fentanyl or methadone have some slightly different kinetics. Fortunately, fentanyl also, however, follows first order kinetics. So what do we do for extra or breakthrough dosing? I like to start here. The first principle is, for an extra or breakthrough dose, we should offer that extra dose every T max. And of course, maybe you use PRN if the patient wants it, or SOS. This is if the patient would like it, because they're still having pain. And of course, the patient can always refuse. What I do want to be very careful about is, this is with the immediate release preparations that we have. Never use the extended release preparations for breakthrough dosing. They are for maintenance. So what becomes important, because if you remember I said, well, it's about getting to that maximum effect. This is the maximum point at which patients will experience pain. It's also the maximum or reduction of pain, reduced amount of pain. It's also the point at which patients will have the maximum risk of side effects. So if the patient's pain is not well controlled and they do not have side effects, it's not going to get any better. It's time for an extra dose. If you look in the pharmacokinetic literature, you'll find a range, typically in Micromedics or Lexicomp, 45 to 60 minutes. We highly recommend we wait until there's a maximum risk of side effects. If the patient has no extra side effects and they're still in pain, it's time for an extra dose. Don't wait 90, 120 minutes or longer. And you can see the effect. We give that extra dose as a breakthrough and the concentration increases a little further. With this extra dose, the patient is again testing, is my pain controlled? Am I getting any effects that I don't like? So every breakthrough dose is a test of efficacy and safety. Well, when we look in the pharmacokinetic literature, we see this range for oral dosing. We see a shorter range for subcutaneous dosing. Again, please wait until you have the maximum risk of side effects before offering an extra dose. And if we give the medication intravenously, the literature shows us another range. Some of the tables actually suggest 6 to 10 minutes. We're actually suggesting we wait 15 minutes, as some of our older patients have delayed cardiac output. It may take them a little longer. We want you to be safe. And what I've also learned is my nursing colleagues have difficulty giving medications any faster than once every 15 minutes, particularly on a busy floor. Even if I'm using patient-controlled analgesia, I lock out patients for those 15 minutes. So a take-home from this talk is to use medication carefully. You want to wait until Tmax, 60, 30, 15 minutes, depending on the route. And I ask everybody to memorize that. We don't want to wait 90 minutes. We don't need to give it once an hour for IV dosing. We could give it every 15 minutes if a patient was really challenged. So what about constant pain? How does that work? Let's talk about it. The second principle is what we want to do is achieve steady state. To do that, we need to dose the medication once every half-life. Does everybody remember the definition of half-life? Again, as I presented this even last week, I asked folks, and many said it's the time it takes to reduce the concentration by half. That's not correct. It's the time it takes for the body to eliminate half the dose that was given. So if I give 10 milligrams here, after one half-life, 5 milligrams remains in the person's body. Now, it turns out for all routes of administration, that's effectively 4 hours. So to get to steady state, I want to dose once every 4 hours. This is the curve that I will develop with these increasing plasma concentrations. You can see that within 5 half-lives, I'm at 87.5% of steady state. And after 5 half-lives, I'm at 100% of steady state. Ideally, what I'm trying to achieve is plasma concentrations that rise and fall, what we call the peaks and the troughs, that are above the concentration needed to control the pain, and below the concentration where side effects start to occur. The therapeutic window or therapeutic index, we're right in the middle of it. Now, we know when we start treating patients with significant pain, we're probably not going to be in that window. And in fact, we have no idea how much medication they will require. We may simply want to start out with breakthrough or SOS doses, ask them to take them, and then we'll catch up. We'll talk about that in a moment. When we look at immediate release morphine, what we need to remind ourselves, and this is by mouth or by rectum, Tmax is 1 hour, half-life is 4 hours, steady state will be in 20 hours, 5 half-lives. Once a day, we can check with the patients and see how they're doing, and we can adjust the dose that we're providing routinely, and maybe the breakthrough, if they have no side effects. Starting dose with morphine, the maximum dose are both variable. Some of you may know the literature. You might even look up one of my early papers with inpatient infusions. On occasion, we were at extremely high doses for a very small number of patients. So we can provide you with a number of reference cards. We give this one to all of our learners, all of our faculty, what I want people to remember is Tmax 15, 30, 60, depending on route. Half-life is 4 hours. Schedule the dose every half-life to get to steady state and use the Tmax for breakthrough doses. We typically recommend 10 to 20% of the 24-hour dose, or once you know the 24-hour dose, simply divide by 6. It works perfectly well. I can also provide you with medication tables if you would like to see the kinetic parameters for all the medications we use in palliative medicine. We've isolated those out. We've had many pharmacists have a look at the tables. We're very confident in them. Happy to provide them to folks. So, what do we do for starting titration? Let's think about a patient like Bill. This was a gentleman I met actually in the country of Cyprus. You can see he started out with cancer of the prostate. 3 years later, he had significant bone metastases, what he would have described as a severe, excruciating toothache, shooting pain down his perineum, cold legs, and numbness. If I was thinking about it, I'd say, oh my goodness, this story is very consistent with mixed pain, both nociceptive and neuropathic. What we do know is that even for neuropathic pain, opioids may be helpful. So if Bill's not had any other analgesics, I'm inclined to start by giving him a breakthrough, asking him to take them, spending the time to teach him, and then seeing how he does in 24 hours. I don't start with an arbitrary routine dose. Some patients respond very quickly to low doses. Other patients may need very large doses. Now, some of my colleagues say, oh my goodness, Frank, that's a lot of medication. Well, that's actually, if I start with 10 milligrams morphine, it's equivalent to 100 milligrams of tramadol. It's really not that much. But if you're concerned, in the frail or the elderly, you can start with 25 or 50% of the dose, 2.5 or 5 milligrams by mouth. Simply recognize where you are. My guess is the patients will not have side effects and probably won't get good pain control, particularly if it's a patient like Bill and his pain is 8 out of 10. Now, if Bill happens to be already opioid tolerant because he's been using tramadol 100 milligrams every 6 hours, then what I'm going to do is calculate the oral morphine equivalence and then double it. So I know he's been taking 400 milligrams in 24 hours. We divide by 10 for the equivalence. It's about 40 milligrams of oral morphine. I'd like to try to give him, because he has 8 out of 10 pain, 90 milligrams or 80 approximately, but I'm going to use 90 because we just have the 15 milligram. It's easy to calculate. And I'm going to offer that every 4 hours. For extra breakthrough, again, 10 to 20% of the total, which is now going to be 90 milligrams, and offer it every 60 minutes. Of course, the patient may refuse. So for this particular patient, if they're taking 15 milligrams every 4 hours, 10 to 20% would be 9 to 18 milligrams. Let's offer him 15 milligrams. It's exactly the same. It keeps the same dosage format in the home. And maybe you can see why I said simply divide by 6. It works perfectly well in this circumstance. So what becomes important is that Bill takes a pain diary and keeps a record. I want him to write down the last dose he took, how many milligrams. Right now, I want him to write down his pain severity. And since the last dose, I want him to ask himself, did he have any effects he didn't like? And I certainly encourage patients, if they do have side effects, things they don't like, call the nurse or the doctor right away. We actually maintain in our system 24-hour call service. So even if they were to have a difficulty at night, they can call us. Now, you might not be doing that because of resources. Tomorrow's going to be fine, but tell them to call you. I see so many patients wait several days before they call. It's also important for me to teach Bill with this prescription how to actually take it. So if he's taking 15 milligrams every 4 hours, the first dose could be at 10 o'clock. If by 11 o'clock he's still having pain, he could take a breakthrough. Similarly, at 12 o'clock, at 1 o'clock, and at 2 o'clock, he can take the routine by the clock plus breakthrough if he needs it. Most patients don't understand that. They need to be shown it. And I see many doctors don't actually understand. When I ask about the 2 o'clock dose, they say, well, he can have 15 milligrams, but he's still in pain. No, he can have 15 plus 15. I like the pain diary to be displayed, patients to read it or take a picture of it. I adjust based on their pain diary, not based on verbal report. Now, of course, patients can have nausea. We know that. Best medication to prescribe to anticipate nausea is haloperidol because of the chemotrigger zone impact of the opioids that causes nausea. And of course, we're going to need to give a stimulant as well as an osmotic. I prefer polyethylene glycol when we have access to it, or lactulose. Sorbitol could also be used. I want to keep the bowel moving. We know we want to avoid that primary effect and prevent it if we possibly can. So Bill started to take those breakthrough doses. I'm not going to jump ahead of his demonstrated usage. I'm going to catch up by reading his pain diary. So how does that work? Well, day 1 follow-up, I'm going to call him, ask him for his pain score, ask him whether he had any effects he didn't like. I'm going to ask him to read the pain diary, and I'm going to write down the total number of routine doses. In this case, let's say he took all 6 on time, 90 milligrams. And how many breakthroughs did you use, Bill? Well, I used 6, a total of 90 milligrams. We know he didn't have any side effects, but his pain control is probably not what he's hoping for. When we ask him, he says, well, if I could be 2 or 3, that would be ideal. Because I've had pain for a long time and I don't want to get drowsy, so let's aim for 2. So now he's got 180 milligrams. I'm going to make that his routine total dose in 24 hours. Divide by 6, I'll get 30 milligrams. Again, take my range or divide by 6, and I get 30 milligrams and 30 milligrams. I can put the 2 exactly the same dosing. What about day 2 follow-up? I'll just wait for the screen to catch up. Are you seeing? Yes, here we go. So day 2 follow-up. Let's imagine his pain is a little bit better. Now 4 out of 10. No side effects. How much did you take? Let's read your pain diary. He took all 6 of the 30 milligrams, total of 180. He took 4 doses, so he didn't, he didn't take 6 doses of breakthrough, he only took 4, a little bit less. And that totaled 120 milligrams. 300 milligrams total. Let's now make that the routine by dividing by 6, giving us 50 milligrams every 4 hours, and the consistent equal dose for the breakthrough. Just turns out it works perfectly in that sort of range. What about day 3 follow-up? Gosh, Bill says, I'm feeling better. I'm sleeping more. I'm moving around better. I'm eating better. And I don't have any side effects. So we know it's working. We're getting closer. We've used the kinetics to get us to the place where Bill feels comfortable and it's been safe. Let's again catch up. Take the 300 milligrams that he's taken routinely, plus now, when we read his pain diary, he'd taken only 2 doses, another 100 milligrams. Let's build that into the routine. Divide by 6, well, that's a little bit more difficult, isn't it? So we're going to round up or down a little bit. Let's say 65 milligrams. Again, 10 to 20% would be right in the range. Let's give him the 65 for both the immediate release to take every 4 hours, as well as the immediate release to take as needed. What I want to say very carefully is do not titrate any faster than the patient has demonstrated it is safe. Now, this is, of course, the patient. We're doing this on an outpatient basis or in an inpatient unit where I'm not there all the time. The nurses are looking after the patients. This is the way I will handle it. If I was able to be at the bedside, I could do a slightly different titration technique, but I still wait until Tmax before I move on. That would be a conversation for another day, what I would call a rapid titration technique. This technique that I'm showing you is what we do in the far majority of our patients. So, I get good control. How many of you, if you're given an antibiotic to take 7 days, 3 doses every day, you actually take all 21 doses on time? My hand's down because I never do. I have trouble remembering all 3 doses. It's challenging. And now we're asking a patient to take doses every 4 hours, including at night. They haven't been sleeping, but now they are, and we want to wake them up. So fortunately, the pharmaceutical industry has helped us by developing extended release preparations. Typically, these are offered every 12 hours. It does take still 5 dosing intervals, not the half-life now, but the dosing interval. It takes 5 dosing intervals to really get to steady state, 2 to 3 days. So we don't want to use these for titration. They're there just for maintenance. We also have to tell patients not to crush or chew the tablets. If they do, they get all the medication at once. Now, people worry about that respiratory depression issue. I promise you, our Food and Drug Administration knows patients do crush and chew these. They've still licensed the products because though patients might get quite drowsy, it's not likely going to cause respiratory depression. It's not the risk we've all worried about. The distinct advantage is these preparations have a peak effect that's a little later, as well as a dosing interval that's about 12 hours. It means that the patient could take it at, let's say, 9 o'clock in the morning, 9 o'clock in the evening. They don't have to wake in the middle of the night. Fortunately, again, remember the kinetics. They peak at 2 to 3 hours, dose every 12 hours. It's a dosing interval, not at the half-life. Still the same medication in the tablet. The half-life is still 4 hours, but the way the tablet breaks down, it delivers the medication using these type of kinetics. So steady state is approximately 60 hours. Again, no maximum, and we start based on demonstrated use. So the alternative for Bill on day 3 could have been take that 400 milligrams. We know it was safe. We know his pain score is good, and he's telling us my function is better, my sleep is better, my mood is better. Instead of giving it every 4 hours, we could take the total and divide it by 2 because we're going to offer it every 12 hours. extended release morphine, 200 milligrams every 12 hours. The breakthrough still needs to be the immediate release, so we still need to do our calculation, 10 to 20%, and decide what we will offer. Now, I've been using numbers here that may or may not be consistent with your products that you have. You'll need to know what's actually available in your part of India. Then we might do a little rounding up or rounding down. Now, sometimes our patients can't afford the extended release products. So what could we do to avoid waking up at 2 o'clock? They're taking it 65 milligrams, maybe every 4 hours. What we can do is we can actually offer an extra or breakthrough dose at bedtime. They'll get a higher peak. They won't need to wake at 2 o'clock. And by 6 o'clock in the morning, their plasma concentration will be close to the usual trough. Now you might say, oh my goodness, side effects? Not likely. It's only a breakthrough. They probably have been taking them already. And if they had a little side effect, it might be simply some drowsiness, and they're trying to have a good night. Now, what do we do if a few days later, Bill calls us and his pain is bad again? He has not had any side effects. He's used some extra breakthroughs. What we need to recognize is this is probably disease progression. We probably need to get a little more history from him and understand why, but at the same time, catch up and build this into the routine dose. So again, maybe 720 milligrams, divide by 2, would give us 360 milligrams. We do have formulations that would allow us to give him this in extended release. You'll need to check yours, and a similar calculation, 10 to 20% of the 720 milligrams, giving us 100 milligrams every 1 hour. Now, you might be reacting to this number. Some people have said to me, oh, that's very high, Frank. Well, we've looked at the literature. It's actually not very good in this area. But what we've seen, and in our own practice, patients with metastatic cancers like Bill's to their bones, which may be causing them significant problems, the average use is in this sort of range in the literature. What we need to know is, what's the average use in India for patients who are reporting good pain control and good function? Now, clearly, some are less, some are more. We need to refine this, but we shouldn't get excited about the numbers. We should be looking at the patient and saying, is this helping? Are you functioning more effectively? And are you having any side effects? If it's safe and it's helping them, it's the best use of medication. Now, one other concern with our water-soluble opioids like morphine, even oxycodone, hydromorphone, if you have access to it, are clearance concerns. I'm going to use morphine as my model, but it does apply to any of these water-soluble opioids. It does not apply to fentanyl or methadone, both of which are fat-soluble and inactivated by our livers. When we take morphine sulfate, as it passes through our livers, slowly but surely, it's metabolized into morphine 3-glucuronide, morphine 6-glucuronide. These are actually the products that give us the majority of the effects. The morphine 6-glucuronide is the product that gives us the best possible analgesia. The morphine 3 is the sinister one that causes most of the central nervous system side effects, starting with drowsiness and then possibly other things, confusion. The worst would be the myoclonus seizures. Now, what we know is these are all water-soluble, and they move passively as we excrete water. They are not dependent on creatinine clearance. If you're putting out water, you are eliminating these 3 compounds from your body. Why is this important? Well, in the face of oliguria, which could be coming from dehydration, could be coming from renal failure, or in our world of palliative care, the dying patient, they lose their ability to eliminate the medications. What does that mean? It means as the volume of urine drops, we need to reduce or stop routine dosing. We do know that to effectively clear the toxic products from our body, we need at least 500 milliliters of urine output per day. What we recommend, and this is simply a Ferris guideline, is decrease the routine dose by 50% if the urine volume drops below 500 milliliters. The urine will be amber. So if you're talking to a family member on the phone, what's the color of the urine? And by the time it drops below 250 milliliters of urine in 24 hours, or it's really dark brown, or there's no urine, stop the routine dose and continue breakthroughs if the patient needs them. Well, what do we know? You might be saying, oh my goodness, the patient's going to have pain. No, they're not, because they're going to have plenty of morphine 6-glucuronide staying in their bodies. They will have pain control, effective analgesia until death. If they were to get a little more pain, you can always offer a breakthrough dose. Now, the reason not to give more is because then we'll fill up the concentration with morphine 3-glucuronide, and we can cause the delirium, the confusion, the drowsiness. Very clear. So somebody just asked the question, what about the effects of diuretics? It's all about the volume. If you're putting out a larger volume, you're going to put out more and eliminate more of these products faster. It's all about the volume. So what happened with our patient like Bill? Well, because of his progression of his illness, he actually developed an incomplete spinal cord compression. His legs were weak with AIDS. He was moving with AIDS, I'm sorry. He was incontinent of urine and stool, but Bill had good pain control. In fact, he was not taking the doses I was describing. He was using 180 milligrams of morphine every 12 hours. He did occasionally use some breakthroughs, about 4 per day, because he felt that that was useful. It was particularly on activity. Of course, as you can imagine, everybody had thought about the pathophysiology, and they were using other medications as analgesics. The amitriptyline, he was getting routine zoledronic acid once a month to help slow the destruction of his bone by the metastases. This conversation today is not about the pathophysiology and how to use all these different other medications. It's about effective use of opioids. And again, I will say, you need to treat the cause based on the pathophysiology and then treat the experience. If morphine is appropriate or another opioid, use the kinetics. While I was there on a later visit, his friends came in, opened up a bottle of wine, sat down with us, and he raised his glass, as did they, and he said, I give you permission to tell my story as long as you will say in every class, thank you for listening to me and understanding my pain. Thank you for carefully thinking about how to treat it. And most importantly, thank you for giving me back my life. Bill actually, he had the spinal cord compression, but he really wasn't getting cachexia. He actually lived for several months like this with good pain control because he had a team that followed him routinely around. So please use the pharmacokinetics, the catch-up technique, not only in pain management, but in all that we do in palliative medicine. I routinely challenge my colleagues, what's the half-life? What's the Tmax for the medication you're using? If you don't remember, and I don't, I'm happy to send you our kinetics tables, put them on your smartphone and look them up. Let's do the best for our patients. So I'm wondering what questions people have.
Yeah, we have some questions from beforehand and there are some in the chat. So I'll go through the questions that we received before. And thank you, Frank, for that wonderful lecture. It was a pleasure to hear from you as always. So shall we start with the questions?
Absolutely.
Right. So there's a question from Gaurav, who works in a Max hospital in Delhi. So Gaurav, so he asks, when you say you need to rotate the opioids, and he anticipates some problems with increasing dosages of opioids like side effects. So he's asking, shall doctors try adjuvants along with opioids? For example, ketamine, antidepressants, anti-neuropathic pain medication. And he has also requested you to share any patient information literature if you have with you before starting the strong opioids. Thank you.
Sure. So I want to emphasize this was not a talk about pathophysiology of pain and what medication would be appropriate for it. This was a talk about careful use of opioids. So I did start out by saying, if opioids are appropriate based on pathophysiology, this is how to dose them. Of course, you're going to use different medications. There's another whole complex lecture I could give about pathophysiology and medication choices. Absolutely. I want to distinguish between knowing the kinetics, which is what this was about today, and how to dose, versus comprehensive talk about pain management. And I've seen a couple of other questions in the chat about that sort of thing, carbamazepine, other medications we might use. Of course, we have a comprehensive toolkit today, many different medications. I also want to emphasize this was not a talk about the use of methadone. Methadone kinetics are completely different.
Sure, Frank.
What else?
Yeah, and I think if they want further literature or resources, they can directly mail it to you, right?
Yes, of course. Please send me an email. I'd be happy for people to email me, and I'm happy for people to have my slides if you'd like to share them.
Thank you, Frank. Moving on to the next question. So the next question is from Dr. Shrenik Ostwal. He's a graduate from Tata Memorial Hospital and working in a hospital in Indore. So he asks how to taper opioid in non-cancer conditions pertaining to pain and breathlessness.
How to taper or how to titrate?
How to titrate, that can also be done.
The same. Yeah. Again, the question is, what's in the non-cancer population? What's the pathophysiology? What's causing the pain? And we must never forget the total pain. It's not just nociceptive and neuropathic, but it's the physical, the psychological, the social, spiritual. And then based on what we believe the cause, we choose the best analgesics, co-analgesics, and we use these kinetics to titrate them. If an opioid's the right choice, we believe it will be helpful, you do exactly the same titration technique as I've demonstrated. If you believe it will be gabapentin that will be helpful, you use the principles. What's the half-life? What's the Tmax? How am I going to use it? With a medication like gabapentin, we often start with some low dose of routine once every half-life. We need to adjust it once we get to steady state, which gabapentin's half-life is about 8 hours. So it's once every 2 days. That's just an example. It's the same concepts. And again, I could share the medication tables. And then you can see all the data from both Lexicomp and Micromedics. These are great questions.
Thank you. Thank you, Frank. The next question is about the route of administration. So people have asked about the route of administration of opioids. For example, take morphine. if there is any topical action of morphine over wound management, if morphine can be given sublingual or rectal, particularly in patients when they're approaching the end of their lives. Thank you.
Wonderful question. So morphine is water soluble. And the first thing to point out is that our skin has a keratotic layer, which is actually lipids. It's actually dead cell wall structures. It's our skeleton. Morphine will not pass through intact skin. But if there's a hole, a wound, where the keratotic layer is gone, we've actually seen topical morphine can work beautifully in wounds. That's another completely different talk. The principles and the use are very different. And then you asked about, the second question was about routes of administration. Could we give it sublingually? Yes, we have, particularly in patients at the end of life. They're often lying at sort of 30 degrees, propped up a little bit in bed. We place it against the buccal mucosa, making sure we've got a glove on so we don't get a human bite or get contamination from the patient. It will trickle down the mouth. It will trickle down trachea. It will trickle down the esophagus. We've seen in many patients, although maybe it's a little slower, it works well. You can also give it rectally. What I call mucosal routes, oral, buccal, rectal, all have effectively the same kinetics as oral. Tmax, approximately 1 hour. Of course, you can give these products intravenously or subcutaneously, exactly as we described. And I use actually, when I've got patients at home who are dying, the question is, am I going to use the buccal route? If it's low dose, probably. If I'm needing a higher dose, I'm probably going to go to the subcutaneous route of administration to make sure they're getting the medication. And of course, if I have an intravenous access, I don't start a new intravenous access, but if I have it, I'll use it. I hope that's helpful.
Right. Thank you, Frank. And I think we had these questions which are relevant to today's topic. The rest of the questions, because they're a bit different from today's topic, we'll take up in later sessions. And I think Dr. Bhatnagar is asking to stop sharing the screen and everyone can come forward in like an open forum and ask questions, right?
No, I just want to stop sharing the screen so that we will come on the main screen. We want to talk to people, those who are sitting over here. So everyone will come on the screen, at least people, those who are talking.
Sure. So let me see the trick of where my screen control is gone.
Yeah, it is gone now. We can see you in on the whole screen. That's what we were doing.
Perfect. Yeah. Perfect.
You, Frank. There are a few questions. Yeah, there are a few questions in the chat, Frank. People are, they're asking for your email ID. Would you?
Oh, sure. I can put that in the chat. No problem.
Put it in the chat.
Just hang on 1 second. Let me just change to everyone. Somehow I ended up with somebody else. But sure, I'm happy to put that in the. And you can use that email. That's the best one for me. frank@palmed.us. That's my personal email, and that's the one I use for business.
And most of the questions, actually, most of the questions, Frank, have been discussed throughout your lecture, right? I'm sorry, I think you were saying something. Please continue.
No, I was waiting for you.
No, I was going to the questions in the chat, and if you see,
sure.
you'll see that most of it has been discussed throughout your lecture. You have touched upon the diuretics and the morphine dosages, titration, side effects. So those things have been controlled.
They have been covered. The side effects have been covered, yes. Sure. So
one question from, sorry, go ahead. I'd
like to see one. We use IV morphine trial, 1.5 milligrams to 2 milligrams every 10 minutes. That is actually consistent with some of the kinetic literature. And if you're sitting there with the patients, and staying with them. This is a semi-rapid titration. You do have to be careful. You have to be there. So if a patient was at home, I would not do that. But you're describing a semi-rapid titration. Sorry, you were going to say, Dr. Shushma?
Yeah, there is a question from a person from Indonesia that they use morphine drip at in the Indonesia we use morphine drip at to breakthrough IV. Can you please speak yourself because the question is not very clear, Edward? Can you speak yourself?
Hello, good morning.
Yeah, good morning. Go ahead.
Am I clear audible, ma'am?
Yeah, you are audible. Go ahead.
Okay, thank you. In Indonesia, we currently use morphine drip. We use steering pump for decrease the acute pain in patient in emergency room. And we do that because there are a lack of human resource now. We cannot do every 15 minutes, so we give about 10 milligrams for 24 hours and give breakthrough dose in IV morphine. And how about Mr. Frank decided about
But
So Frank, is he not clear? Can you mute?
Edward,
Maybe can you give explanation?
so Edward,
Yes,
we're
yes,
having
hello?
we're having trouble hearing you. It's the connection. I wonder if you might write me in my email and ask your question that way. I'm happy to answer it. If a patient,
Okay.
for us, just for the larger audience, for us, if we have a patient with a pain crisis, we may well start an infusion, but we may only offer the breakthrough doses using what we call patient-controlled analgesia, so that they push the button. We count the number of times they push the button. We do offer it every 15 minutes. Once we have some history, then we give the infusion as a catch-up, and we still give them the option to push the button. So you do, with patient-controlled analgesia, you actually get faster control, less side effects. Patients report better relief, and they will, particularly if they're going home, they'll often go home faster. I really like, for particularly hospitalized patients, patient-controlled analgesia. Do you use it at Ames or at Tata?
Pardon, Dr. Frank?
I was just asking Dr. Shushma, or I see
Thank
Dr.
you.
Dedehar
Yes.
or Aaron's there. Do you use patient-controlled analgesia at Ames or at Tata?
We use patient control analgesia only in the post-operative acute pain. Otherwise,
You don't.
yeah, we
You
don't.
don't use it for cancer pain.
Cancer pain, we use it in a very, very acute situation, and once the pain is stabilized, we have to monitor.
We'll be there as soon as possible.
Sure.
Okay. Right.
So,
And this is
Frank, thank you very much. It is 7:30. Everyone, thank you for joining early in the morning. Frank, it was an excellent presentation. As usual, I think it is always, we get so much of extra knowledge when we hear you. And as it's like everyone must have appreciated the same fact that they must have really, you give insight of all the things in depth. So thank you very much, Frank, and thank you audience for joining early morning. It was wonderful to see almost 130 and 140 participants. We will have you again, Frank, because this is the easiest platform, and I think there are so there is one lecture due, is that how to choose analgesics, and then there is a lecture due that how to use methadone or other this thing. And there was one question that how to take care of breakthrough pain when patient is on fentanyl patch from a MD student. Would you like to give the answer right now? Because this is an important question. People wants to know that.
Well, fentanyl patches are very different technology. We don't have oral or fentanyl available to us. And if we're sending the patient home, we need to give them the equivalence using the 10 to 20% of what we're giving them as fentanyl, but it needs to be immediate release morphine.
Thank you.
So it becomes more complicated, doesn't it?
Thank you. So thank you once again, and Arun, thank you very much. Nisha, thank you everyone for joining us, and we will like to see you again very soon. We will plan on all the topics which we could not cover today, but it was an excellent overview of uses of morphine for cancer patients. Thank you very much.
My pleasure. Thank you, Aaron, for putting all together the questions. Hello, Jaita.
Thank you, everyone. Bye-bye.
Before leaving, I would like to once again congratulate our winners of the Cancer Aid Society Award. Suresh as a nursing award, Asha and Suresh. Asha is a social worker, Asha Rani, and Dr. Stanley for doctors. So thank you very much and congratulations once again.